All right, let's jump straight into this. Welcome to this high-yield explainer on intracranial infections. If you're prepping for your boards, we are basically building your ultimate study guide today. We're going to cover those classic exam triads, nail down the clinical patterns, and most importantly, zero in on the urgent warning signs and absolute contraindications you just cannot afford to miss. So let's start with a scenario. Picture this. You've got a patient presenting with a killer headache and some focal neurological signs. But here's the kicker. No fever. None. So my question to you is, if they don't have a fever, can you definitively rule out a brain abscess? Test writers absolutely love throwing this exact setup at you to see if you'll take the bait. Well, the answer is a hard no. Believe it or not, fever is only present in about 50% of brain abscess cases at the time of diagnosis. Yeah, just half. So basically, no fever absolutely does not mean no abscess. It completely blows up that perfect textbook presentation we are all kind of conditioned to look for. Okay, so here's our rapid-fire game plan for this explainer. We're hitting the classic triad myth, the absolute contraindications, mapping out abscess stages, tackling venous sinus syndromes, and wrapping up with opportunistic infections. Let's dive right into section 1 and tackle that classic triad myth head-on. We need to look at what actually walks through the clinic doors versus what the outdated textbooks say. We all memorize the classic triad, right? Headache, fever, focal neurologic deficit, boom. But here's the thing. While headache is for sure the most common symptom, showing up in like 75% of patients, seeing all three of these together is a massive trap. Honestly, that perfect trio only shows up in less than half of all cases. If you're standing around waiting for all three before you suspect an abscess, you're going to miss the diagnosis entirely. Moving right along to section 2, this is all about absolute contraindications and emergencies. These are those hard lines in clinical practice you just do not cross. Listen to me closely on this one. Lumbar punctures are completely 100% contraindicated if you suspect a brain abscess or a subdural empyema. Just don't do it. Why? Well, grabbing CSF here gives you basically zero useful diagnostic info, and far worse, it massively spikes the risk of a fatal cerebral herniation from the mass effect. Always get neuroimaging first, period. Now, check out this comparison, especially the speed factor. A brain abscess might take weeks to months to brew in the tissue, but a subdural empyema, that is a blazing fast medical emergency. Because there are zero anatomical barriers in the subdural space, the pus literally just runs wild. It spreads so rapidly that immediate neurosurgical drainage isn't just an option, it's absolutely mandatory. To crush this on your exam, lock in this specific clinical vignette for subdural empyema. It's almost always a younger guy, second or third decade of life, and the whole thing kicks off with frontal sinusitis. They get this progressively worse headache, then contralateral hemiparesis, so weakness on the opposite side of their body, and often seizures, right before a rapid decline in consciousness. Hardwire those keywords into your brain. All right, on to section 3. We're mapping out the brain abscess and looking at its stages. This is going to give you a super solid framework for those tricky location questions. It's basically a game of real estate. The source of the infection points exactly to where it lands in the brain. Ear infection, like otitis media, that is heading straight for the temporal lobe or cerebellum. In fact, a crazy 90% of cerebellar abscesses are otogenic. Paranasal or dental issues, frontal lobe. And if it's traveling through the blood, hematogenous spread, you're looking at multiple abscesses sitting right at that gray-white matter junction. And they don't just magically appear fully formed. It's a chronological progression. Days 1 to 3, you're in early cerebritis. Just inflammation, a necrotic core, and lots of edema. Days 4 to 9, late cerebritis. The pus actually forms. Then days 10 to 13 is the early capsule stage, where a wall starts building. Finally, day 14 and beyond, late capsule. You've got this dense wall, but the reactive astrocytes around it mean your patient is now at a super high risk for seizures. So here is your golden rule. The second you see the phrase ring enhancement on MRI or CT, you know exactly where you are. That enhancement marks capsule formation. So timeline-wise, you are right smack in that early capsule stage, days 10 to 13. That is a gigantic exam buzzword. But wait. How do you tell a ring-enhancing abscess apart from a ring-enhancing necrotic tumor? This is absolute radiology gold right here. You use DWI, diffusion-weighted imaging. Think about it. An abscess is full of thick, gross pus, so water can't move around easily. That restricted diffusion gives you a bright, increased DWI signal and a low ADC. Under chronic tumor, the water moves freely, facilitated diffusion, so low DWI, high ADC. Memorize that formula for sure. Section 4 already. Let's blitz through venous sinus syndromes. These are pure pattern recognition gold for clinical vignettes. First up, cavernous sinus thrombosis. The absolute hallmark here is proptosis, that bulging eye. Why? Because an infection from the sphenoid or ethmoid sinuses spreads right to the cavernous sinus, which happens to house cranial nerves 3, 4, and 6. So you get the bulging eye, you get ptosis, the droopy eyelid, chemosis, and extraocular dysmotility, meaning the eye muscles basically just freeze up. Next is Gradinego's syndrome, huge high-yield eponym alerts. It's a nasty complication of otitis media hitting the transverse or sigmoid sinuses. You need to lock in this specific triad: otitis media, a 6 cranial nerve palsy messing with outward eye gaze, and deep retroorbital or facial pain. See those 3? Click Gradinego's and don't even look back. Now this one is probably my favorite exam trap: superior sagittal sinus thrombosis. You get the usual headache, fever, confusion, but the real hallmark, the trap answer, bilateral leg weakness. Sounds completely random for a brain infection, right? But anatomically, it is perfect. That sinus runs right between the hemispheres, directly over the parasagittal motor cortex. And what does that specific cortex control? Yep, your legs. Finally, Section 5. Let's finish up by talking about parasites and opportunistic infections. We're going to directly compare 2 massive CNS infections that you will 100% see in case studies. Let's put them head to head. Neurocysticercosis, caused by eating Taenia solium tapeworm eggs. The absolute must-know buzzword, it is the most common cause of new-onset adult seizures from endemic regions. Compare that to CNS toxoplasmosis. That's a reactivation of Toxoplasma gondii, seen almost exclusively in severe immunocompromise, like HIV patients with a CD4 count under 100. Their MRI is going to light up with multiple ring-enhancing lesions deep in the basal ganglia. For toxo treatment, there's a pharmacology step you cannot forget. Step 1, you load them with sulfadiazine and pyrimethamine. But step 2 is you absolutely have to add folinic acid. And actually, they don't just add it for no reason. It's specifically there to rescue the normal cells and stop the patient from developing severe megaloblastic anemia caused by the pyrimethamine. Okay, we've covered a ton of ground today. Quick pop quiz to see what stuck. What is the single most common cause of adult-onset seizures worldwide in endemic regions? If you immediately thought neurocysticercosis, you absolutely nailed it. You're well on your way to mastering these clinical red flags. Keep leaning on these visual frameworks as you study, and seriously, watch out for those exam minefields. But before I let you go, think about this. If a severely immunocompromised patient walks in presenting with those exact same seizures, how does your entire diagnostic algorithm change? Chew on that, keep crushing your prep, and I'll catch you in the next explainer.